GLP-1 receptor agonists like semaglutide, liraglutide, or dulaglutide are a class of drugs primarily used to manage type 2 diabetes and obesity. They mimic the natural glucagon-like peptide 1, an incretin hormone that plays a vital role in glucose metabolism and appetite regulation. However, their effects extend beyond blood sugar control, influencing multiple organ systems. GLP-1 is naturally released from enteroendocrine L cells in the intestine in response to food intake. They bind to GLP-1 receptors, which are found in multiple organs like pancreas, the gut, the brain, heart, kidneys, and the lungs. And these receptors belong to the GPCR receptor family, and they work by increasing intracellular cyclic AMP, activating phosphokinase A, and other signaling pathways. This leads to several physiological effects. GLP-1 agonists, they stimulate insulin secretion in the pancreas from the pancreatic beta cells in a glucose-dependent manner. It's important because they will help lower blood sugar without causing dangerous hypoglycemia. They also suppress glucagon release from alpha cells, which reduces the liver's glucose production, and some studies suggest that GLP-1 agonists may promote beta cell proliferation and reduce apoptosis, potentially preserving pancreatic function over time. One of the hallmark effects of GLP-1 receptor agonists is delayed gastric emptying. By reducing the rate at which food leaves the stomach, these drugs help control postprandial glucose spikes. They also promote early satiety and reduce food intake by acting on GLP-1 receptors in the central nervous system, particularly in the nucleus tractus solitarius in the brainstem. This effect goes beyond gastric emptying, as direct activation of GLP-1 receptors in the brain has been shown to reduce meal size and overall caloric intake. Appetite-suppressing effects contribute to weight loss, which is an important effect, making these drugs extremely valuable for obesity management. More recently, the cardiovascular effects are becoming clear, and beyond their role in glucose metabolism, GLP-1 receptor agonists have been shown to provide cardiovascular benefits independent of blood sugar control. They can reduce blood pressure, they improve endothelial function, and they have different anti-inflammatory properties. Clinical trials have demonstrated a reduced risk of major cardiovascular events in patients with type 2 diabetes using GLP-1 agonists. They could also serve as potential neuroprotective, and GLP-1 receptors are found in the brain where their activation has been linked to neuroprotection and reduced neuroinflammation. Preclinical studies suggest that these drugs may have potential benefits in Alzheimer's disease, Parkinson's disease, and stroke recovery. And more recently, there is also evidence of improved memory, neurogenesis, and potential benefits for mood and anxiety disorders. GLP-1 receptor agonists may play a role in non-alcoholic fatty liver disease by reducing liver fat accumulation and improve insulin sensitivity. There is research ongoing about their effects in polycystic ovarian syndrome, and they are linked to reduced inflammation and possible pain modulation. One other important effect is on the urogenital system. They increase natriurease and diurese, and that's important in the peri-operative care of our patients. While GLP-1 receptor agonists provide significant benefits, they present key challenges in the peri-operative setting. The most notable concern is delayed gastric emptying, which can increase the risk of aspiration under anesthesia. Studies have shown that a significant number of patients on semaglutide still have solid gastric contents after prolonged fasting, raising questions about the safety of these medications in the peri-operative period. Although no definitive link to increased aspiration risk has been established, careful preoperative evaluation and airway management is crucial. Another critical factor is the impact of GLP-1 receptor agonists on blood glucose regulation. These drugs improve glycemic control and carry a lower risk of hypoglycemia compared to insulin, but maintaining normal glycemia is key. Peri-operative glucose levels should ideally remain between 4.4 and 10 millimoles per liter, with a slightly higher post-operative target. both hyperglycemia, which increases the risk of infection and electrolyte imbalances, and hypoglycemia, which can lead to cardiac arrhythmias and neurological complications, must be avoided. Drug interactions is also another point to emphasize, because drug interactions also warrant attention, particularly for patients taking weight-based medications such as levothyroxine and anticoagulant drugs, and drugs with narrow therapeutic indices like warfarin and digoxin. Rapid weight loss from GLP-1 receptor agonists can alter drug metabolism, requiring careful monitoring. Dual-acting GLP-1 GIP agonists like tirzepatide pose an even greater risk to their profound effect on weight loss. Cases of thyreotoxicosis have already been reported in patients taking tirzepatide and levothyroxine. Additionally, GLP-1 receptor agonists can contribute to sarcopenia, particularly in elderly patients, as they promote not only fat loss but also reductions in lean body mass. This, combined with polypharmacy and frailty, may heighten peri-operative risks, making individualized treatment plans essential. Finally, their effects on hydration and nutrition must be considered. These medications can cause nausea, vomiting, and volume depletion, which, when combined with a standard preoperative fasting, may impact recovery. It's important to ensure adequate fluids and electrolyte management is key to prevent complications. With the rising use of GLP-1 receptor agonists for both diabetes and obesity, further research is absolutely necessary to fully understand the perioperative implications of patients taking these drugs. For now, close monitoring and a personalized approach to anesthesia and the fasting guidelines and proactive management of potential drug interactions and metabolic shifts remain essential for patient safety. Managing patients on GLP-1 receptor agonists in the perioperative setting is an evolving challenge, and recent guidelines offer some key recommendations. In June 2023, the American Society of Anaesthesiologists published a consensus-based guideline recommending that GLP-1 receptor agonists be withheld on the day of surgery for daily dosing and a week before surgery for weekly dosing. If a patient has severe gastrointestinal symptoms or did not stop the medication, elective surgery should be postponed. In cases of uncertainty, gastric ultrasound can help assess residual gastric content. The Australian and New Zealand College of Anaesthesiologists they takes an even stricter stance, advocating for rapid sequence induction in all patients on GLP-1 receptor agonists who require general anesthesia. More recently, in January 2025, a multi-organization consensus statement from UK-based anesthesia and diabetes societies introduced updated recommendations, including shared decision-making with patients about the aspiration risk, continuing GLP-1 agonists throughout the perioperative period while following standard fasting guidelines, assessing aspiration risk individually, considering patient factors, drug properties, and the surgical procedure, prioritizing regional anesthesia when feasible to reduce aspiration risk, using point-of-care ultrasound when appropriate to guide perioperative management, optimizing anesthesia and airway management strategies, including prokinetica, rapid sequence induction, tracheal intubation, and positioning techniques to reduce aspiration risk. One challenge is that fully reversing the effects of GLP-1 receptor agonists on gastric emptying requires stopping the medication for at least 3 to 5 half-lives, which for long-acting drugs means a 4-week cessation. This is often impractical, especially as patients may only see their anesthesiologist shortly before surgery. Extended fasting has been suggested, but no clear fasting duration has been established to ensure gastric emptying adequate before anesthesia. Overall, while these guidelines provide a structured approach, the best perioperative strategy still requires individualized decision-making based on patient risk factors, type of surgery, and available monitoring tools like gastric ultrasound. Gastric ultrasound has become an important tool in anesthesia, particularly for assessing gastric content and volume before surgery For patients on GLP-1 receptor agonists who are at a risk of delayed gastric emptying, this technique can be valuable in guiding peri-operative management. Optimal position for gastric ultrasound is the right lateral decubitus position, where the stomach contents naturally shifts towards the antrum, making assessment easier. However, if this position isn't feasible, like in critically ill patients, in trauma patients or pregnant patients, the semi-recumbent position with the head elevated at 45 degrees is the best next option. From an anesthesia risk perspective, gastric ultrasound helps stratify the aspiration risk. An empty stomach suggests a low aspiration risk. Solid gastric content indicates a high aspiration risk, requiring modified anesthesia techniques. When fluids are present, volume measurement is key. Volumes under 1.5 ml per kilogram are generally safe, while volumes over 1.5 ml per kilogram increase aspiration risk. For patients on GLP-1 agonists, these real-time assessments provide an individualized approach to anesthesia planning, helping to determine the fasting adequacy, the need for airway protection, and whether to delay surgery. As the use of GLP-1 agonists increases, gastric ultrasound is becoming a valuable addition to the peri-operative risk assessment. In bottom line, we can say that these medications are incredibly useful, but require careful peri-operative planning. The key points: they affect multiple organ systems, particularly the gastrointestinal and metabolic systems. They should be held before surgery to minimize aspiration risk. Glucose levels should be closely monitored, and gastric ultrasound can be a useful tool for assessing aspiration risk in certain cases. Collaborations between anesthesiologists, surgeons, and endocrinologists is crucial for optimal patient outcomes.